Morning, everybody. My name is Paul Byrne. I am the interim director of the John Doster Health Ethics Centre, and my other job is I'm a newborn intensive care physician. And it's my great job today to introduce the speakers, sort of keep things going, and hopefully get you guys to participate actively in the symposium. We've been doing this for many years now, and it really is the discussion which the talks generate, which is what people want, and very often the most memorable moments are from the interaction between the audience members and the speakers or the panel. The mixture of healthcare professionals is something unusual for me to be attending a conference where it's not predominantly physicians, and I really enjoy that exception. That's no disrespect to my colleagues, but there's a certain limited vision if you've all physicians in the room. Anyway, I've got two housekeeping items which Carol asked me to mention. One is that she was successful in getting the Royal College of Physicians, etc., formal approval of this course for all of you who are here and need credits. That will be able to go through, which is, I think, key. And we're always in debt to Carol, who's sitting at the back there. Every single year I forget to thank her, so I will thank her before we even start today. Because without her, this symposium would never happen, and that's not an exaggeration at all. The second thing is that Dr. Wasylenko's talk is being recorded, apparently in terms of legalities. I have to inform all of you of that. So it's a great pleasure and a privilege to introduce Eric Wasylenko to you. You've all got his biography on the handout here. So I won't embarrass him by spending 15 minutes going through it in great detail. He is a palliative care physician, and he's somebody I've gotten to know over many, many years, mostly in an administrative capacity. I've served on several committees with him, and one in particular, which he chaired, and I was astonished at his ability to harness a very diverse group of people into working together on a vision around health ethics. Herding cats came to mind to me several times during those many, many meetings. And he showed those qualities which I believe are key to being a very effective and successful physician, and basically the kind of physician that I would like to have when I'm ill. He showed extraordinary patience and understanding and compassion and all of those things. And I remember those meetings very, very carefully. He has many formal appointments, as you can see from the bio. He has dedicated his professional career to looking after those who ultimately are the most vulnerable of all, those who are facing death at some point in their close future, as opposed to the rest of us who are ultimately facing it, but we seem to forget about that most of the time. And he has also been hugely influential province-wide in terms of organizing systems approaches to various aspects of healthcare. So without further ado, I would invite him to come up and give us his keynote presentation on enabling autonomy and vulnerable trust for decisionally incapable persons.
Thanks very much, Paul. That's very generous. Hello, everyone. And those meetings were herding cats, and there was only like one or two physicians in it, so I'm not sure what that says about the physician bit, Paul. But Paul was saying that he's happy or pleased to be in a group without a lot of physicians. I'm looking around the room, and this is a group without a lot of men, which is not uncommon for a healthcare audience. And as many of you know, I come from an environment, a home environment, where I don't have the benefit of having very many XY chromosomes either. The dog, the granddaughter, the 6 daughters, and of course my wife are all female, so I would prefer a little bit more balance in the audience. But having said that, I will carry on, and I'm not sure if it's really a very good strategy to start out with a little bit of a ride or excuse, but I will start by saying that this talk is an attitude talk only. So it's not a technical talk. It's not going to be highfalutin ethics principles, and it's not going to be a lot of theoretical detail around how we need to change the system towards a better way of helping people, us and our patients and families, make decisions. But it will be a bit about attitude that hopefully will set up the day for the rest of the day and the speakers. So there are some key problems for us. We don't have a consistent way to rapidly and effectively assess capacity for decision making in our healthcare system. So lots of people working on it. I just met a couple of people who are working on a study on that this morning, and looking really forward to, with our colleagues, trying to develop a much better way that we can help enable people's decision-making capacity, the autonomy, and the communication of that. Second big problem is we've not really settled the question, who gets to decide? So is it physicians who get to decide? Is it patients? Is it families? Is it advocates? And which kind of advocates? And is that even a reasonable question to say that it's one or the other? Or should we be focusing on the potential and healthy confluence of a number of key informants for a good decision making for a person who is vulnerable and can't decide for themselves? The third key problem is that we don't really have an adequately entrenched mechanism for naming and communicating goals of care. We have the mechanism, and I for sure have to say that because I helped lead that initiative in the province to develop new things called goals of care designations that completely replace do not resuscitate orders and the like, as well as advanced care planning, so that people can actually think about their health care wishes in concert with their values and wishes and beliefs, communicate those things with their family members, discuss them and communicate them with their providers, and then have a reliable mechanism by which those can be transmitted to any point in care where people arrive. Because in today's healthcare, people arrive in circumstances and in sectors where they have unfamiliar care teams. So the care teams are unfamiliar to the patient, and the patient's unfamiliar to the care team. And for those reasons, we're not very good yet at being able to consistently apply a person's choices, values, beliefs, wishes into the urgent, in-the-moment decision-making that has to occur for patients who are sick and who are vulnerable. So we've got the mechanisms, we just don't have it yet entrenched. And that's a little bit of a commercial message. All of you, or most of you, probably know about those mechanisms now. We need to find a better way to engage the public into that mechanism, so that when they go in to see their nurse practitioner, their physiotherapist, their doctor, the emerge folks, the ambulance attendant, that they know and can stimulate those conversations about, yes, I do have a goal of care designation, I do have an advanced plan, or why aren't you talking to me about that? Once we get the biggest healthcare resource in the province, i.e. the patients, to be part of that mechanism, we'll have had success. The fourth problem, and what I'm going to be talking about today, is that our society and considerable health care teaching says that individual choice and respect for autonomy trumps just about everything else. And it is this latter problem, and I'm calling it a problem, that I'm going to address this morning. So I've got this pretty complex title, Enabling Autonomy and Vulnerable Trust for Decisionally Incapable Persons. That's probably the last complex thing you'll hear today. So I first need to start by telling you I have no conflicts of interest to declare. I don't have commercial support for this. or much else. I don't have industry funding. That was just a joke. I don't have industry funding or research activities regarding this, and I'm involved in some other grants for advanced care planning, but not for industry-supported issues. The opinions I'm going to express today are really my own, and they're not reflective of official positions of any of the organizations with which I work. So here's the general route I want to take today. I want to just challenge about trust about what? What are we really talking about? Get into some cases in brief just to ground us in the clinical environment, because that's always important. And then try to challenge a little bit on the idea, the notion of autonomy, and does it work or not in general, and does it work for specifically vulnerable populations? And then move a little bit into the notion of personhood, and is it a concept that's about being alone as individuals, or is it a concept about being together in relationship? And that has an implication on the notion. And then talk a little bit about trust in society and what patients' trust looks like, and then maybe a little bit on enabling some mechanisms for vulnerable trust without, again, getting into really specific, detailed mechanisms. And I should say, for some of you in the audience who may be at or who may be wanting to go to the Alberta College of Social Workers, there's a meeting. There's two workshops coming up October 17th in Edmonton. And I'm giving a 3-hour workshop on advanced care planning, goals of care designations, and the way that decisions are made around that. So that's a place for getting a little bit more of the technical information about where we're going. So trust about what is how I'm going to start. And I'm thinking about this in the context of my clinical practice. I was giving a talk recently to a group of about 450 healthcare providers who were mostly in palliative care. And I was at a long session, about 3 hours, and I ended it with a poem that I had created. And I'm not a poet, but it was really a reflection on, with pictures of what I called pleading eyes of patients when we meet them and when we continue to interact with them, how that connection between their eyes and my eyes, or the eyes of any healthcare provider, changes and alters and reveals this really deep notion of trust from patients, and commitment from a provider, and that fiduciary commitment that I presume Brendan's going to talk about later today. So here are some of the things that I've heard patients reveal to me about what they're looking for from me. It's not just my expertise and my competence. They say to me and to others, I trust that you have my best interests at heart. They want to know that they can trust my competence. They say, I trust that you will hear me, and hear me deeply and genuinely. I trust that you will be honest, and you'll be gentle with your honesty. I trust that you'll pay heed to my wishes and values and beliefs. I trust that you will honor your commitments. I trust that you will be attentive to the journey of my loved ones. I trust that you will know your limitations. I trust that you will not abandon me, regardless of my choices. I trust that I matter to you as a person and as a patient. I trust that whatever should be held in confidence is held in confidence. I trust that my dignity matters to you, and I trust that I am safe in your care. And that latter one is really something that embodies the entire notion for me. So let's just talk about a few stories. Lorraine is first, and these aren't exactly real stories, but they're very close to real stories. I've changed the details just for confidentiality reasons. Lorraine's a 47-year-old woman, divorced about 10 years ago, no children, no parents or siblings left alive. She has many friends and associates throughout the world, and many close ones at home. She's a high-performance athlete on the world stage, and she suffered a traumatic brain injury. She was deemed incapable of making her own decisions regarding her treatment, her care, her finances, and her living arrangements, so all spheres globally. And she's currently in ICU and is ventilated. Excuse me. Her friends, who are really her circle, her family, are of two minds regarding her will to live, her will to fight on, and whether or not she would appreciate living with an altered physical and mental capability, as she looks like she's going to if she survives ICU. There's no advance directive that exists, nor is there a written expression of her views on such matters. So we don't know. And her friends are passionately on either side of the fence about this. What would she have wanted if she could tell us what she wanted? And she can't. She never will be able to, likely, and we have to make a decision for her, and we have to make a decision as the healthcare team, but also as her friends who will bear the responsibility, the burden, maybe a well-taken burden, or maybe the feel of a moral burden on them that they don't want to take for helping to guide the decision about how we're going to treat her. It really matters to them, and it should matter to us. So the challenge is, how do we interpret, thanks, Victoria. How do we interpret her life approach that those friends all knew about and apply it to her current circumstances? We can only impute what she may have wanted, or what she may be like, by the way that she lived her life. We also need to understand how to support her friends who view her potential journey in diametrically opposed ways and who view their task as being her steadfast advocates. If we don't choose the path that they believe is best for her, they have failed her. That's what they tell us. So it really matters to them. George is an 82-year-old man with moderate dementia and terminal esophageal cancer. He's expected to live about 4 to 6 months and died from his esophageal cancer, not from his dementia, although his dementia is rapidly progressive. He lives in a supported living facility and has been there for the last year. He's got one estranged son in Atlantic Canada who's not really part of his life. He's got long-term neighbors who actually visit him about 5 days a week when he was at home and then now in the long-term care facility, and they've cared for him previously in his home environment. He's now developed acute renal failure for which dialysis would help him live and would also relieve acute suffering from renal failure. So we've got a technology we can use to help him through these struggles temporarily and to also support his life. His personal directive says, "I don't want to live like a vegetable." And that's not an uncommon thing for a personal directive to say, unfortunately, so not very helpful. What does a vegetable mean, and what can we impute from that bit of language, which was really common language 20 or 30 years ago? His named agent died years ago, so that's not helpful. And the family physician who's in charge of the medical care for George wants to know what to do next. So not an uncommon scenario. The challenge for us, I think, is interpreting his expression of wishes in light of medicine's ability to support that physiology and prolong his life. So we can do those things, and it might be a really reasonable, valid choice. And it's a particularly big challenge in our current mode of being able to care for people with chronic illness, because we can't keep their physiology going. We can keep them alive. We can keep the anima within their lives going almost indefinitely for many kinds of illnesses, and we don't know if it's the right thing to do or not. We also need to understand his particular sense of how he expressed dignity in his personal directive and how he expressed indignity. Adil is a 51-year-old man with glioblastoma multiforme, stage 4, so he's got a brain tumor, the most common kind, and it's a dastardly one for him. He's an accomplished engineer. He values his ability to reason really importantly. He's in hospice, his wife is distraught, and she's unable to approach any conversations about death with us or with him. He's asked us about the possibility of assisted death, but now that option just isn't something he wants to consider anymore. But it was obviously front and center in his mind for a period of time as he started facing the decrements from his illness. Each day brings more marked swings in his mood and in his judgment, and that's what happens for lots of people with brain cancer, that their frontal lobe and the higher executive functioning just isn't working as well, and it fluctuates, it goes up and down. So this man we know, some days is the man we know, and some days it's not the man we know, because his judgment's different, it's impaired, his memory is poor, and his mood swings cause his behavior and his attitude to change dramatically. So the challenge is understanding the difficulties of knowing how to act as his fluctuating competence provides varying degrees of confidence in our hearts that what he says is really what he wants in an enduring way. So we often say, ask the patient, Does the patient know? Can they give us an expression of their wishes and they say, I want to do X, or I demand to do X, or that you do X? How do we know that that's a real expression of what is an enduring wish or value for that individual when we only really have the ability to see today what he's like and what his verbalizations are? We also need to understand what are the components of physical and cognitive and existential suffering for him, as with all these other people that I've described. So that's really important. Does it matter to him that he's like this now? Would this be the worst way for his life to be lived as he approaches death? And then there's John, who's a 32-year-old man with pervasive developmental delay. He's had a lifelong seizure disorder with variable treatment success. He's had a recent, really bad systemic infection for which he was in hospital. Seizures became intractable. They were reasonably well controlled previously. So really good efforts at aggressive control have been tried, basically all that could be tried. And because nothing was working, he required admission to an ICU and complete sedation, just as a trial of intervention to give him relief from what we presumed was suffering from his seizures. After 7 days of unsuccessful attempts of seizure abatement, despite that sedation, his family was approached by the care team regarding a decision about stopping that intervention and focusing on a palliative approach to care and allowing him to die. So our challenge is understanding our particular duty to John's needs regarding stopping physical and maybe some emotional or psychological suffering. We're not sure how much there would be, without the advantage of any reference points regarding prior expressions of his values. So everyone else that I talked about at least had the opportunity to express their values and what life meant to them and what care meant to them. John does not have that. He's never had that. We have to impute something about him, and not about him as an agent who can talk to us about how he values life, what dignity or indignity means to him. So the other challenge is fully embracing the notion of dignity for a man like this who's completely reliant on what I'd call our compassionate response and our interpretation of his personhood and what it means to be alive or not alive, without a history of agency and without any opportunity for agency to occur. So in the landscape of this decision-making conundrum, we always have to ask, who are these people's advocates? Who bears responsibility for deciding for this particularly vulnerable person? Is it the clinical team alone, or in a sort of primacy role? Is it family members? Is it the Office of the Public Guardian, the rep, or any other guardian, if that's the issue? Is it the formal and informal supports, people who know these individuals best, who can guide us, or who bear responsibility for actually influencing the decision? And our primary questions need to be always, and this is probably all of healthcare, but certainly in these environments, how do we best care for this person? That's a pretty simple question with an unfortunately complex answer for many, many people. But it is the question, and it probably should be the question that guides us all the time. And how do we best decide for this person? Because what we're talking about today is actually not just the care, but the decisions that go into deciding, which kind of care or interventions will be invoked. We ideally decide with, but the particular issue about capacity problems is that it's not always possible to decide with the person. We decide with every bit of evidence that can be garnered about their lives from our imputing, from our observation, from declarations, whether verbal or oral, and from how we and family members interpret this person. Recognizing, of course, that we all have our own biases around that, our own lived experience, our own fears and worries that will make us evaluate this person's risk for suffering, their desire for living, in accord with how we would view those things if we, in our empathetic stance, were looking to be in that particular position. So I always ask us to remember who we are. So we're really just a resource to fellow humans who seek our knowledge, our experience, and our wisdom to assist them in living as well as they can. And we're really nothing more than that. We're experts. We also have at our disposal the goods of society that we can apply towards somebody's health or protection or prevention. But really in this decision-making mode, this is all we are. Sometimes we're the deciders, And such patients in some circumstances might be completely at the mercy of our wisdom, our judgment, and our intentions. And those three things are the key. It's about attitude, it's about expertise and knowledge, but it is our intentions of what we mean to be doing with, for that individual that really guides the beneficence of our work. So as a professional, we actually are, the meaning of the word professional is that we profess to do our utmost to provide for those in our care, even at our personal expense. It's not a promise about things that we can't attain, that are impossible to manage. It's not about being perfect. And in all these circumstances, we will never know if the decisions we make were the right ones or perfect. But the relationship is predicated on trust. And that trust is about what we have professed, generally and specifically to this patient, and what has been implied that's been professed. Here's the rub. We're a society that values choice. Who could ever argue with the desire for choice? And in every deep, problematic moral issue that we face in healthcare, the language is often ending up as language of choice. So the assisted death debate is certainly about that. Abortion debate is certainly about that. We just demand and expect. And who could argue that choice is a bad thing? It's wonderful, and we love to have it. And then the law and ethics discourse and the norms of behavior, I think, scream out in our society, our very self-focused, driven society, that we're to worship at the altar of autonomy. And I use those words deliberately because I think that it is this notion of respect for autonomy has superseded most of the and many of the other parts of healthcare that are just as important. So progress isn't always progress. And I ask the question, does a focus on choice and self-determination substantially interfere with our role as healers and guides? If we are singularly focused on asking a patient, what do you want? And some physicians and other healthcare providers are, they say, I'm the purveyor of information. I'll tell you what your options are. Don't ask me my opinion. And don't ask me what you would do if you were in my shoes, doctor. Lots of people increasingly now say that's not my role. I am here to give you information only, not to give you guidance or wisdom or tell you what I might think for myself. So especially our commitment to the unique vulnerability of patienthood and what it means to actually be a patient and in that vulnerable position looking to someone else for their guidance and wisdom and not just their technical expertise that increasingly, as you know, we can get from Google anyway. So are these notions mutually exclusive? The notion of choice, self-determination, and then dependence or reliance on somebody else who has a beneficent view towards us. There's a practical reason to get this right, and I'm not sure this is really easily seen. I should have blown it up more, but this is from The Economist, The World in 2015 by John Parker, and many of you would have grown up, I'm not sure if this is going to work. I don't think so. Is that working? No. On your left-hand side of the screen is the classic pyramid of population. So each of those lines is a 5-year increment, age 0 to 5, 5 to 10, 10 to 15. There's a little dotted line you can see near the bottom, that's 15, and then the next one up is age 65. You can see in that first year, I think it was from 1970, how many people were at the bottom of this pyramid population. Lots of kids and lots of people in the middle age years earning income and productively earning resources for the population to be able to manage. And very, very few people in the 65-year and older range. Now, the next one over is this year, 2015. And you can see the difference, how relatively, there's fewer young people. There's a larger bulge of people in the middle who are the economically productive engine drivers for our economy. And I use that not because that's a particular value, but to say that's the way that we garner the resources so that we can care for others. And then there's a much larger group of people above the 65-year-old line. And then on the right side, in 2060, so a ways away still, it looks even different, substantially. There's a much smaller group of people in the middle and as the youth of the country, being able to actually provide that economic might so that we can take care of adequately everybody, and including the people who are elderly. Now, I need to say, when I started medical school in 1979, and I was writing the histories out as a medical student, you always said, this elderly 65-year-old man, and that's just not the case anymore. And as I approach that, I get to say that that's just far, far off. And we know that. I mean, people are really, really well often at that relatively young age now. But the volume of people that are in that older category, the fastest growing population segment is the people who are 85 and over. Right? So that's got some implications for us. I'm not saying it's a bad thing. It's got implications, though. And how are we going to be able to adequately help and care for and house all those people who may not be contributing economically to our society? Now, they contribute economically in an indirect way, and I'm certainly not saying that the economic contribution is what derives value as a human being, but it is one of the things that we use as an instrument to make sure that we can care and respond adequately to the needs of the entire population. So is this going to be a problem? This is just a picture of advanced Alzheimer's disease, and many of the people in that last pyramid look who are in the 70 and older range, and some people younger now, will be dying from this disease or will have this disease as they approach the late years of their life. And that's going to have a vast impact on our notions of personhood and about choices in decision making as well. So we are very proud of the fact that in Canada now, the average age for women to live is about 82.3 or something, and men is about 81.7 or 9 or something like that. But the most important statistic is how many of those late years are lived in a way that those people want to live, with reasonably good health. And it's actually about 9 or 10 years now of substantial disease burden that people would say for themselves they would not want to have. People are living longer, they're not necessarily living better. But most of those people say, I want to still be alive, and thank you very much for helping me to be so. So they're living in a very different way. And it's interesting to think about that, though, because of this notion of plasticity, of understanding and acceptance of your condition. So we know from very good research that lots of people would say, I would never want to be like this particular disease you can name or condition you can name. If that ever happens to me, don't help me survive, don't make me survive, don't save my life. But people who actually do land in those situations very often say, thank you for keeping me alive or saving my life. I do want to be here. And this is sometimes, for some of those people, the best life they've ever had, and they really appreciate having been there. So we know people nominate wishes with certain values, especially as younger people, and that those values and particular choices do change. So in dementia, the issue is for us in deciding who is this person who's before us, which manifestation of the person is to be honored. The person who we currently see before us and who has their needs and their aspirations potentially, and their joys and their sorrows and their suffering, their hopes, or the person who was before they became demented and remembered life in a different way and who they were in a different way. That's going to be always a very tough question for us. So my premise is we want to presume to say that personhood confers a special consideration regarding health care, including duties towards such a being, because they are a person only, not because of anything else about them, their value, their might, their status, whether or not they're fully functional, if you want to use that word, in a mental capacity point of view or a physically productive point of view, just because they are persons. And how we define that is going to be key. So my argument, and this really comes more from the nursing literature than anywhere, is that we must start looking at ourselves as relational beings rather than this self-focused, autonomous person, an island unto ourselves, who doesn't bear existence and personhood in relation to others in the world. None of us exists alone, and in fact, our being, we would still be human beings, but the essence and the character of who we are and how we relate to the entire world is in relation to the entire world. So in healthcare, when we make decisions, others who are making decisions with us or for us or who have access to the resources have influence and control and agency and impact in a deliberate way on whether or not the person lives or dies and how they might be treated. That's our job in healthcare, to help influence those decisions and to help guide people in their choices. So that's really relevant for people who have become decisionally incapable or who always were decisionally incapable. How we actually apply those decisions and those mechanisms and the resources for those people is the test of how we are as compassionate people. So then there's the concept of vulnerable trust. We're focused really always on the duality of a healthcare fiduciary relationship, that we commit to this individual above all else. And I want to return back briefly to those parameters of trust described at the outset. So again, I trust that you have my best interests at heart. So you're competent, you'll hear me. You'll be honest but gentle with your honesty. You'll pay heed to my wishes and values and beliefs. You'll honor your commitments to me. You'll be attentive to the journey of my loved ones. You'll know your limitations. You will never abandon me despite my choices. I trust that I matter to you. Whatever should be held in confidence will be. My dignity matters, and I'm safe in your care. All those are the things that people are trusting us about as they expose themselves in this vulnerable way to our care. So in the larger sphere, societal understanding that we collectively will respond in a way that really honors that trust in what we call expert diligent care, complete compassion, and a focus on dignity, even when we don't have the benefit of knowing what that person would have chosen, is really important. And so John, the fourth person I described, who has never been able to express for himself how he wants us to treat him or what it means to be dignified, what dignity means to him. He can't tell us that, hasn't consciously, perhaps, we don't know this, but hasn't consciously thought about that or declared it. We still have to have trust as societal members that for people like that, the mechanisms will take care of him in a way that we would expect to be cared for as well, if we could express those things. That's really important for us to remember, and partly because of that graph I showed you about the population changes. I often use that to describe to people that my worry that economics will drive morality. And soon enough, as I say, people will be starting to really throw out the phrase, there's a duty to die, and partly because of that economic picture that I showed you and the population picture. So what does that mean about how we take care of and treat the most vulnerable in society who cannot declare wishes in an autonomous way? Part of the argument about why autonomy by itself or respect for autonomy is not a substantive enough on its own principle. So here's how I would describe a particular form of autonomy: acquiescing to this thing called the social good of healthcare. And that's what patients do when they arrive at our doors or in our offices, via trust in that institution that we call healthcare, that everybody knows what it is, and also the relationships of a provider with their patient or their client. It's considered a form of autonomous choosing. So I say, here's what I know healthcare is going to be like. I'm submitting myself to the goodness of those people and their expertise. That is a form of autonomous choosing, even though the deliberate decisions sometimes are out of my hands. And must I always declare my decision, or can I legitimately place trust in the decision of another? Would be a different way to ask the question. And in a previous generation, that would have been the common thing for the more elderly person to say, and I long for these days still, I trust you, doctor, tell me what you think I should do, and I'll believe you, rather than the more modern approach where people say, thanks for your information, I'll go check Google and then I'll get back to you. So dignity is a real key point in this whole conundrum. So we make dignity-preserving decisions that I think are at the interface between what we call benign paternalism and respecting people's autonomy. Do we respect a person merely because of their place in what we call the human family, or do we respect a being due to their potential to be in the human family? And that gets a little bit back to the abortion debate, but also to the increasing number of people in the human family who are very different regarding their mental capacity and their potential for being humans as we know, due to the potential within them as a person, i.e. their value. Is that why we might want to respect a person, because of the value that they bring to society? Or is it due to their former membership in the human family when they're not now? Do we respect people after they're dead and their legacy and their being because they existed as a member of the human family? Those are all, in my view, components of this notion of respect and dignity. But I'm not convinced of respect for autonomy's hallowed ground in healthcare as an exclusive principle. It's an important one, but it's not, for me, such a central one. I'm convinced of its central place in the notion of dignity, so that people can actually declare for themselves and name for themselves how they want to be viewed, how they want to live, and how they want people to care for them. But dignity, for me, is a component of beneficent care and beneficent decision-making, and both of those are linked. So when we think about society in general, though, we go about our relational lives understanding that our carers and society writ large will be trustworthy when we are no longer decisionally capable and vulnerable. And because we go about our lives knowing that, we can actually flourish better because we're not fearful. The moment we start to understand that those choices of ours are taken away by somebody who we may not trust or know or shouldn't trust or might not know, we get a lot more worried, and we start to put up defensive barriers and protection mechanisms so that we're protected in our vulnerability. So if for some of these people, like John in my examples, and others who no longer have an agent or their personal directive is out of date or whatever, we can't turn to prior expressions of their sense of dignity or our wishes for guidance. There is a special trust that society has, as trust commitment, that people know there will be normative ways that we'll treat them. All right? So again, autonomy is so important, and people's ability to name their choices are so important, but not everybody, and increasingly, not everybody will have that opportunity. How do we make sure that we've preserved in some decent way a sense of how we might manage for those people when we don't know their choices? So those judgments ought to be consistent with acceptable and transparent norms. So things like consistency and fairness, people need to know that that's there in place. And that's part of what lots of us are working on around standard ways of people declaring their wishes, naming them so that we can understand what they want. We need to be able to depend on ethics guidance and publicity of the ethics values and the normative values that we will use in healthcare decision making. So people need to know better. We need to know better, but the population needs to know better for sure who actually gets to decide. If the very self-actualized and potentially frustrated family members come in and say, look, this is my decision to make for mom, they need to understand how that interplay is supported legally, but is also supported ethically in her best interest. We haven't done a very good job of actually sorting that out, I think because we're in a transition phase. We need to make sure that there's available legal advice and recourse to the courts when necessary, in a quick way, a responsive way. We need to make sure that decisional guides in lay language are available for people to be able to understand what they're deciding, how they might decide, what components of information can add to the decision. We place this huge, huge burden on people to make life-altering decisions for themselves or for their loved ones, and don't equip them with the moral guidance, with the sort of the comforting care afterwards to assure that they're doing okay, nor with the language and the understanding of the full range of considerations that need to be employed. So I've had well over 100,000 clinical interactions in my career. That's a lot of experience. Lots of you have had similar experience in healthcare, and you get to plug in all those bits of data. You don't think about them, of course, every time, but you plug in all those bits of experience and data into this focus that you have with this one person who's in front of you. An individual who's making these decisions may be emotionally charged, may be vulnerable themselves, and having to make these tough decisions, frankly, are just not equipped to make them with that full range of experience, knowledge, and understanding. How do we help them do that? Because their contribution is vitally important. But can we put it all on them? We need better formal dispute resolution mechanisms and approaches, and we need to address this notion of moral stress, which is a positive, healthy thing, moral distress, which is not a good thing, and the moral burden that people feel not only for the in-the-moment decision-making, but for the rest of their lives. And as most of you, I think, believe, that the unit of care is the whole family, not just a particular patient or client. We have to think about not just this interaction today, but what those people carry as burdens for decision-making their whole lives. We've figured out, I think most of us hopefully have in healthcare, how to absorb that burden of decision-making for those people we're professing to care for, but that's not a commitment that a family member necessarily has been asked to make and is willing to make for their loved one. I think I'm not going to talk much about futility here, but I will want to say that there's this notion of relentless progress we're making in medicine, success after success after success in keeping people alive and helping support their physiology. I think it blunts our appreciation for the primary purpose of care and the notion of accepting vulnerability about the inevitable outcome of death. So the technological successes can dramatically improve our chances of meeting person-centered and societal goals, which is true. But they can also cause more confusion regarding what the right thing is to do. So because we can do X, ought we do X, is often the question we ask in ethics. So what are the right decisions? Hard to say. My stab of it would be the right course of action is almost always a course that's chosen if we have done these things. We've considered on the moral dimension with a bunch of other people who also have considered on the moral dimension, bringing all that they bring in, their spirituality, their knowledge, their expertise, their whatever experiences they've had as a person, and their understanding of the moral dimension. We've attended to our collectively determined laws. We live in this society as relational beings. We buy the fact that our laws apply to us all. We might not like them all. Some of them we really despise, but that's the way that we live in our society. We've addressed personhood over the pure technical healthcare considerations. So what is it about this person who is not a collection of physiologic mechanisms, but is a person with a mind and a spirit or soul, however you want to pitch that, and a whole series of connections through relationship. That's what defines their personhood. And then we also want to make sure we've recognized our human and professional limitations. So again, back to earlier, we can't be perfect, and we shouldn't expect to be. And then finally, we need to make sure that our decisions are well-intentioned towards beneficence, not merely towards, and I use that word deliberately, merely towards respecting a person's named or declared choices. So even though we're sometimes able to manipulate this physiology in amazing, dramatic ways so that we can increase the chance of people living in various versions of good quality, not as good quality, but as what they would call a desirable manner, much of that deep personhood experience of living and dying is well beyond our control, and I thank God for that. So it is not up to us. We have a big part to play. And so coming from a place of humility is really important. We recognize our place as merely interveners in a person's life journey. Really important interveners, but not more than that. And hopefully we do it as expert and beneficent guides. Thanks for your attention. Happy to answer any questions, challenges, or discussion. We've got a few minutes, I think. Paul, how many? And there's mics there as well. I think if you don't mind coming up to it, that'd be great.
Yeah, hi, I'm Andrew Pollux of Calgary, Alberta. And I've got a question about the goals of care designation, which has different categories between R1 and C2. I think it's about 7 different categories, something like that.
Right.
And so my mother's name is June. She's 89. She has a certain degree of dementia. I'd describe her as partially rational. But with the goals of care designation, that's something that's brought up some annoyance because she's been in a nursing home, say, a bit over a year and a half, maybe 20 months, something like that. And or 21 months, and before that, a few months in Rockview Hospital as a result of a fall. But the goals of care designation, without discussing it with me, I'm her personal directive, they classified her as M1 at the hospital and then at the nursing home. And in discussing it with the doctor, his response is, and again, she's partially rational, I think she'd prefer R1. I would as well as her personal directive. The doctor's decision, he thinks M1's more appropriate, and he even, but he's a good doctor. The doctors I've dealt with, from a medical point of view, I have no problem with them. They're not particularly trained in ethics, but they're trying to do their best ethically. And yet, when I have a disagreement with the doctor over that, and I think my mother holds the same view as I do, we'd rather have it at R1 rather than M1. And incidentally, the doctor said, well, the hospital, if she went to the hospital, they might not respect the R1. And in fact, in visiting my mother, I saw a lady getting CPR who I heard them, because I was in my mother's room, and this was happening nearby to another resident, they were telling the paramedics she's M1, but I'd seen them giving her CPR while she was laying on the floor, which you're not supposed to do if they're M1, although it was for choking, not cardiac arrest. And since I was visiting, I just saw the whole thing going on. So my annoyance with the doctor, though not at all with his competence medically, is that in the disagreement, basically he says, well, if you want to change it, get another doctor. That's sort of not acceptable to me, because my mother and I would rather have R1, but it's not our choice. It's taken out of our hands by him. And he's basically a good doctor, so I kind of don't want him to just say, okay, I'm not going to be your doctor anymore, because he visits the nursing home, once a week and checks on, some group of the people there. So what do you do? Is it legally the doctor's choice or our choice? And how should I deal with that? And generally, if I say that doctors aren't trained ethically, I'm happy to bring them books published by the best academic publishers to support my position. I'll give you books from Oxford Press, Cambridge Press, Harvard Press, saying why I take this position. A doctor isn't going to do that back because they've never had a look at those books, and they have no clue. Books on pertinent to ethics published by the best academic publishers, because that's not their field, however good they are as doctors. So sorry I went on so long in presenting my question, but could you give me some advice on how to deal with this matter? Thanks very much.
So thanks for your question. I'm sorry that your mom's going through those challenges. I will spend a bit of time with you at lunch or another time if you don't mind, because it's a really long answer, but I can give you some help about it because this is a primary area of my work. But I will say, just as a general thing, there is a dispute resolution mechanism, and for me, it's always been about the confluence of the very good wisdom of a patient and their family, together with the expert wisdom of a clinical team, to say what's the best way that we can care for you. And then the goal of care designation is a shorthand mechanism to codify some of those decisions and communicate that to others so that in the event of an urgent or emergency problem, we can do the right thing for her. When there isn't agreement on what the right thing to do is for her and what goal of care designation she has, then there's a dispute resolution mechanisms to make sure that the agreement is achieved before you get into that circumstance. So I'll go over with you how to actually make that happen for yourself if you're willing for me to do that. Is that okay?
Yeah, sure.
Great, thanks. Other questions? Oh yes, Glennis.
Thanks very much, Eric. That was a really good talk. I really enjoyed it, as I always do your talks. And I was made mindful of the way we teach ethics in undergraduate medical education these days, and the emphasis that's put on by the teaching faculty on emphasis on autonomy. It comes late in the day that these young folk with the best intentions in the world, wanting to care for the well-being of their fellow citizens or whomever the residents may be, start reading the Clios because they've got to do their exams, and they come across this provision there about saying they must, in addition to all the ethics, they must reflect on the systematic impact of their care. So my experience in the consultations that I've had have gone two ways. One is where they take the attitude of, they'll say to the patient or the patient's family, what do you want? That's what I have to do. Or they'll say, because they've just recently read the Clios, usually comes late, they'll say, that may be what you want, but I have to consider the impact on the system overall. Do you think there's a space in here? Obviously, it's going to reflect on palliative care and things about resource allocation. I tried to avoid that phrase. Do you think there's a place in here where we should be developing some tools to help the learning process of our young doctors-to-be that's going to help bridge that gap between consideration and respect for preferences and choices and impact on the social instrument that healthcare is?
So yes, with about 97 font. How's that?
Okay.
Glennis, just describe what a Clio is for the audience that doesn't know.
Well, it's part of the Medical Council of Canada licensing agreement for trainee doctors. So they've done their undergraduate qualification. They then have to write exams in the Clios. There's a part 1 and a part 2. Clio is a statement of principles divided, I believe, into, you'll correct me please, Julia, 7 chapters. And it stands for cultural. No, we've got 2 C's in there these days, C2 Leo. So I think it's cultural, clinical, legal, ethical, organizational aspects of healthcare. So our young docs in training are all supposed to know not just the clinical, the kind of anatomy and pathology and biochemistry or whatever. They're supposed to be these great social thinkers as well.
Right, and they're often guided by preceptors who maybe haven't been well enough versed in all that either.
That's right.
So thanks for that, Glennis. And I often look at it in the same way that I might look at how we try to rank order or rationalize the difference in the 4 Georgetown principles. It's not that one trumps the other all the time. It's an association of them all in which happens to have the factors that are relevant to the case that you're determining. So for this particular issue, we see that a lot, and you've highlighted it really beautifully. It is how we meld my personal responsibility to this patient and my need to advocate for them with all the other needs of society members who have just as legitimate a call on the resources as does my patient or any of my other future patients, as well as all the other aspects of that Clio rubric. The trick is, and the wisdom is, that I think many of us recognize as we get on further in years, is that it is the actual wholesome managing, balancing of those that is the answer. So it's really any opportunity we have to jump at that kind of a statement and say, no, it is not just about X or Y. You've made the decision, I ask you, I'll do whatever you say. I hear that a lot. It's also not, I get to tell you because I'm the doctor and I'm in charge of the resources. It's not that either. It's much more balanced than that, and it always has to be balanced. We skew in one direction or the other after all these points of deliberation that I've talked about. You do have a really well-managed ethics conversation. You do have a legal consultation if you require, and you consider all of those things, so it's not just left to the duality of that interaction that hasn't actually been wholesomely applied. We need to find ways to help our students and our teachers to sort out how you balance those things. And also in the environment of saying it's not one that's sort of hegemonous over the other, it always rules, and we just need to be far more careful. So I'm not sure, the specific answer, how we make it happen, but I think some really good curriculum development and teaching, and then sitting down, we're trying to do a little bit better job of the mentoring aspects of schools in medicine, nursing, and many other disciplines, having the opportunity for lots more sessions where you actually go through those with students and say, all right, let's go through this mnemonic and let's figure out how you might actually pay attention to all the factors when you're making a decision and not being so cut and dried. Go ahead. Yeah, go to the mic. Thanks.
So one of the implications that I'm hearing from this is that the care for a patient in palliative situation or end-of-life situation isn't simply a clinical decision. It may be a decision that's made within a clinical setting, but it's going to be a decision that reflects much broader constituency than the doctor's skills and professional abilities and the family's interests or the individual patient's interests, and that we perhaps need to be more inclusive in our teaching.
Yes, I think that's bang on. We also need to be more inclusive in who we get in. So in that list of trust things that I talked about, I trust that you're an expert and you're competent. That includes knowing when you don't have the skills and resources and you must get in a colleague of any discipline to help me. Who can I speak with as a patient who can help me understand this really difficult thing? It's not just so, and luckily, I mean, that's one of the best parts about the change in healthcare, that it is so team-based. We get to use the wisdom and experience and trust commitments of a whole range of people who are better at some things than each of us are individually. So absolutely important bit of teaching as well. Thanks.
Thank you, Eric, for the talk and for the discussion so far.
I thought you were getting up so I could go sit down.
No.
Sorry.
No, I would have struggled up the stairs beside you and told them they could go for coffee, but I'm going to keep it going for another few minutes. One of the things you mentioned in making decisions for folks, and I use the word for because you said that, when you can't any longer make decisions with folks because they don't have the capacity to decide, and particularly in my own case where I'm dealing with infants who've never had the capacity to decide. One of the things you mentioned, which is very rarely mentioned, and I think it's key, and I'd really like you to expand on a little, is the intention of the healthcare professional and the intention of the loved ones. And I don't think we spend enough time thinking about that, because we tend to think, well, of course, all healthcare professionals' intentions are highly honorable and beyond question, etc. But there are often murky depths to those intentions, as we know. Competing operating room schedules, priorities in the ICU, we need beds in the ICU, this kid really should be on palliative care and the parents are demanding that we put in a G-tube or whatever. So can you talk a little bit more about intentions?
And thanks, Paul, for the question. And in your world, I'm not sure if I should talk about personal things, but my week 1 of medical school, just got my white coat. It was really week 1. It was like day 2, family situation in an ICU. And I've remembered to this day how that's burned into my mind about the drama of uncertainty and experimental treatment on my 34-week nephew, which now is absolutely run-of-the-mill stuff. All right. So in your world, the intention about using what we think is beneficent care that's actually really fairly experimental, so that at some future time we will be able to say this is absolutely routine care, is one of the key intentions of medicine. And as long as the population understands that and goes into this relationship recognizing that that's one of the beneficial intentions, and that we have a whole bunch of protections and safeguards against it being done inappropriately, then I think that's part of the trust commitment. And that's why I was focusing a little bit on that sort of societal norm thing, saying, yes, as long as I know that there are these safeguards and there's all this mechanism in place, there are rules around it, but there's also some motivations around it that are public, that are ethically based and are legally based, then it's going to be okay. I'm actually being pretty trustworthy. When I go in for surgery and I'm out, as I'm anesthetized, and all of these busy things are happening around me, I've got to have this trust that all those safeguard mechanisms are in place, and that's what we need to always be paying attention to make sure that we're not dishonoring that very vulnerable trust. Brendan.
Hi, Eric. Thanks. I was wondering if you could talk a little bit about the idea of trust. You probably said trust 1,000 times in your talk, And it's nice to be able to look at the slides and tell that how deeply important a concept that is to you. But I find it remarkable that we don't talk about trust either really as a teachable concept or value it inherently. It's almost like the ether or the water that we're swimming in as fishes, something that we just take for granted that makes everything work. But it seems to me that trust, you can think of trust as a commodity as well, savings account or what have you, and you can certainly diminish that and feel the ramifications of that or gain trust slowly over time. So can you talk a little bit about, and you even reflect on your clinical work, how you steward trust as a physician or as a clinician, and what are the implications of losing trust? Because I think that's something we don't talk about as being a catastrophic outcome sometimes.
Thanks for that. And part of this notion of respecting autonomy is that I can trust you, if you're my physician or you're my nurse or whomever, I can trust you to pay attention to my choices and my values and beliefs. So that's why they're really linked to that notion of respect for autonomy, beneficent care, and trust. Very, very key. So I'm decrying the place of respect for autonomy in many people's minds as the sole thing or the overriding principle, I'm not trying to diminish its importance and value in that notion of trust. So, I'm not sure how to answer your question, but I will go back to that little mention I made about that poem for that talk and this notion of pleading eyes. And people, when I walk into somebody's room or into their home, or they come into my office and it's the first encounter we've had, and they're in the midst of this devastating bit of news or health journey, they have no idea, except from maybe a reputation they've heard of or maybe not, and all their first judgments about me, is this going to be somebody that I can trust? And that's their real important. All those things I said, are you good? Are you competent? Will you get other people involved? All those long list of trust things, I can see it in their eyes. I want to, but I don't know yet. And one of the neat things about many aspects of medical care, and it's not just in palliative care, when you have the opportunity to have a longitudinal relationship with somebody and make a difference to how they feel as people, not just their pain and symptoms, but how they feel as a cared for, valued individual in the busyness of your day, you can see the eyes change. And that's the best way that I can tell you. You see the eyes change. And there is suddenly, days later or moments later, sometimes even if you're really fortunate, a very different interaction between you and them in that space between your eyes, where there is this sense of, I am relieved now. I don't have to worry that you're not going to pay attention to X, Y, and Z. I have faith that you will do as you've promised and that you will do in honor of what I've told you about myself, and that you're also trying to find out or learn about myself. That's the nature of the commitment in healthcare that I think we lose when we talk about whatever you want to do, Brendan, I'll do for you. You tell me what you want, I'll give to you. You get to make the autonomous choice about all of these things. It is a relationship of a transmission back and forth of information, of values, of beliefs, of understanding. That's what creates and embodies that notion of trust for me. Does that help at all? Thanks. Victoria.
Hi. I was just wondering if you could say a little bit more about the proportionate weight you see as when you were talking about the trust in social institutions or having more trust in the social good of healthcare and as an institution, and how you see that being weighed against autonomy. So I'm a big fan of relational autonomy, which I think has the same argument that you made about the view of autonomy alone, or maybe in the older way of being looked at as individuals as being independent, rational, autonomous decision makers without recognizing all the other factors and contextual influences on people's lives. So I think a relational autonomy maybe captures some of those criticisms, but it seemed to me like you were kind of sort of putting autonomy aside a bit or trying to decrease its weight in general, kind of in favor of this more sort of trust in societal institution or the social good of healthcare. So I guess I wondered if you could clarify that, and I guess I have two concerns, if I understood you correctly, which maybe I didn't. But one is where we don't know the values of a particular individual. I think maybe that's one thing, but where we do, if we're relying on the social good of healthcare or the societal judgment, which you talked about, is there a reason why in that sense you would think, because we have pluralistic values in our society, so if we're relying on those, is there a reason that we would want to rely on pluralistic values of society versus the values of the actual individual who's in the moment, that's the healthcare decision about their life and how that should go? And I guess second is I'm worried if we do rely on the social values or those pluralistic values or this sort of social institution in that way, I guess I'm also kind of wondering if you don't think that might contribute to some of the worries that you have about the duty to die or some of the financial pressures of our changing population graph. Because I think in some sense, as I think some of the comments have already raised, we do have already commitments in our society to things like bed allocation, and healthcare providers have commitment to stewardship of public resources, and we do have these sort of systemic pressures already, these economic pressures, and I'm wondering if you think if we put more value on those, if that might not undermine, I guess, the values of individuals more in healthcare, or if you don't think autonomy, and particularly maybe relational autonomy, is one way of actually keeping those balanced. So that's a long spiel, but I'm hoping you could just explain that a little bit more.
Sure, thanks. And I was going to say to you, to your first point about how you'd weight them, it's about 47-53, just to approximate it. So, I love the notion of relational autonomy. I think that is the solution, or one of the key solutions to this conundrum. But I'm not sure that I maybe understand it quite as thoroughly as you would, Victoria. But in my sort of nascent understanding of relational autonomy, I think all that stuff you talked about with incorporating the pluralistic society, the values of society, and how I, as an individual, make my choices in context of that plurality, the laws, the norms, the mores of our society, and how my individual action affects the nurse, how my individual action affects my surviving spouse who carries on with that burden for the rest of her life. Those things are what embodies for me the relational autonomy. And then the choice I get to make for myself, with a whole bunch of other people, presumably, but I still get to make for myself, is not just about myself. So we've taken this word autonomy and saying what you want to do for yourself matters, that's all that matters. You and the group of sort of relational autonomy proponents, of which I'm one, would say that's how you actually get around this problem. You say that you get your choices, but it is in the context of a society, because everything you do and everything you accept from that society is in relation to a whole bunch of other factors, decisions, and people, and what they want from their life. So I wouldn't argue with you at all. I think that it is a problem for us to reject autonomy outright. But I think that the relational autonomy concept is the only way that we can keep it as a important, valuable, central principle. I don't know if I answered you very well. I don't disagree with you. I mean, it is a problem to reject autonomy. My biggest worry is that without really developing the concept in people's mind. I mean, you get to think about this and study it and practice it every day of your life. Most clinicians don't. And when we understand the concept of autonomy in a very self-directed, I'd call selfish, and I shouldn't use that word, but selfish, me-focused way, because it sounds like choice, which is a great value for us in our society, then we miss out the healthy parts of relational autonomy, which you're promoting, I think. Yulia.
Do we still have time for another question?
You have 30 seconds.
30 seconds. So there is a first observation. It's very interesting that you used a vulnerable trust in the title. Usually on the topic of like this, we would be trust with vulnerable populations. So just kind of I would like to chat with you about that, because we do have a long-standing misunderstanding who is vulnerable at which point in clinical encounters or in their health care journey. But the second part that I would like to maybe get some more of an understanding is really the idea of how the profession, that maybe all these questions that we try to answer are just selfish questions of healthcare professionals. And I'm just going to challenge that, because when we think about the classical concept of professionalism, trust is kind of inherently put there without really exploring what does that mean in a reality of clinical settings. Second part, when we think about professionalism and who were the leading kind of proponents of that in Canada would be the Cruises from McGill University, and they have that very much social contract model of professionalism that translates into the decision making in clinical setting by having a engaged, interactive, this share making moment between an expert who is a healthcare provider and an expert on the life that is a patient. I am wondering that this whole idea of erosion of trust is because we are really living in the times that social circumstances changes. And the idea of social good or healthcare as a social good may be, maybe outdated, I don't know, or maybe it is just has to be explored further. So that's me today.
Thanks. Yulia, the reason I put vulnerable where I did is for exactly the reason that you'd be worried about. Vulnerable is a characteristic. It does not define a person. So I think, and in the quote-unquote vulnerability community, there's that really important notion. We can't say who's vulnerable, and individuals who we've classified in that way sometimes really rile against that notion. So I use it very deliberately in the title for that very reason. And now I'm forgetting about your second question. Sorry. Oh, yes. Yeah. Thank you. So are we self-serving when we talk about this as physicians? I think this is the whole ball game around being a good healthcare provider, not only a physician. It is a function of our culture and our times, so I'd agree with you. And we're in the midst of that change, and what I'm doing is being a little bit more sort of way over on the side of one fence and pushing hard against the current notion, because I think we've lost our way and we need to get back in this direction of what we're actually doing, providing in our profession, in our professing of what we're doing in our fiduciary commitment. We need to get back to this sense that, yes, I really respect the place of an individual person and their bright mind and their who they are and their experience. The experience of an individual vis-a-vis my experience as a physician are complementary. They're not oppositional or shouldn't be oppositional. So very much I want to respect the contribution of a person to tell me about themselves, or some mechanism of communicating that, whether it's an advance directive or our family member or whatever. But our social times have said that that is the predominant and has forgotten the other notion of what we're actually doing, helping with vulnerable people who, by the nature of being a patient, which is what it means to be a patient, has that particular vulnerability. And to be a patient, you automatically expose yourself and put yourself in a position of trust. And we need to keep banging on that drum so that we get to a healthier middle with the pendulum shift, where we're honoring people's ability to participate in their care, to name their care. That's the whole focus of patient-centered care, or one of the foci, as well as what we can do beneficially to help them in our calling.